Hello everyone, this video we are going to see about WILM'S tumor.
I am Dr. Celeste Mary, Vice Principal in Administration at Triplum College of Nursing.
Objectives: by the end of the session, learners will be able to define the term WILM'S tumor and enlist the incidence and etiology of the condition, explain the syndrome associated with the WILM'S tumor and describe the pathophysiology and categorize the stages of WILM'S tumor, list the clinical manifestation of WILM'S tumor and explain the diagnostic evaluation, medical management and nursing management of the condition. Introduction about the topic. WILM'S tumor is also called as nephroblastoma. It is the most common malignant renal and intra-abdominal tumor of childhood and adolescent. It is first described by the German surgeon Max WILMS in the year of 1867 to 1918 and is the most common renal tumor. It is the fifth most common neoplasm of pediatric malignant solid tumor and second most common abdominal neoplasm in children. Definition: WILM'S tumor or nephroblastoma is a highly malignant embryonal neoplasm that may involve one or both the kidneys derived by Marlowe. Moving on to incidence and etiology, the tumor occurs more frequently in left kidney than the right. Peak age approximately 3 years and occurrence is more commonly in boys than the girls. Usually the tumor is unilateral, but in 10 cases it can be a bilateral. The disease occurs in about 1 out of 2.5 lakh children. The exact cause of tumor is unknown, but it has been identified that tumor suppressor gene acts to promote normal kidney development, but this gene may be absent or missing in WILM'S tumor. Next, we can see about the syndromes associated with WILM'S tumor. The Vegas syndrome, W stands for WILM'S tumor, A stands for the aniridia, G stands for the genitourinary abnormalities, conditions such as the hypospadiasis, cryptorchidism and renal fusion, and the mental retardation. Second syndrome is Dennis-Dranz syndrome, that is the early onset of renal failure with progressive glomerulopathy, male hermaphroditism and WILM'S tumor with hemihypertrophy of the spine. Next syndrome is the Beckwith-Wiedemann syndrome, organomegaly, macroglacia, omphalosil, hyperinsulinic hyperglycemia. And about the pathophysiology, tumor generally start growing in renal parenchyma or at the tip of kidney. Majority of the tumors present as a single encapsulated mass that separates the normal kidney and tumor. Although the tumor is encapsulated, but the membrane may be very thin and easily torn. But rupture of tumor put the patient at the risk of hemorrhage and dissemination of tumor. Stages of WILM'S tumor. There are 5 stages. First stage, it occurs mostly 43%. The tumor limited to kidney and is completely resectable. And stage 2 is it occurs about 23%. The tumor extends beyond kidney, but it is also completely resectable. Moving on to stage 3, 23% it occurs. Residual non-hematogenous extension of tumor confined to abdomen. And stage 4 is about 10%. Hematogenous metastasis to distant organs. It spread to the nearby organ and also deposits beyond the stage 3. And namely that is occurs mostly in lungs, liver, bone and brain. And stage 5 is about 5 to 8%. The condition bilateral renal involvement is present at diagnosis itself. Next, we can see about what are the clinical manifestations of the condition. It is about large abdominal swelling or mass. The mass is firm, non-tender and confined to one side, and abdominal pain, hematuria, hypertension, and also weight loss will be there, fatigue, malaise, fever, anorexia and vomiting, anemia, polycythemia, hematomegaly and splenomegaly, lymphadenopathy, and early metastasis to adjacent or the distant sites, and the symptoms of lung involvement such as the dyspnea, cough, shortness of breath and chest pain will occur. About diagnostic evaluation of the condition, first we have to collect the detailed history from the parents, and physical examination to reveal the presence of the abdominal mass, and urine analysis that reveals the presence of blood in urine, abdominal x-ray, and blood investigations such as complete blood count, renal function test, blood urea nitrogen, creatinine, biochemical study. These all reveals the conditions, and chest x-ray and abdominal ultrasound, intravenous pyelogram. Or these are the investigations we have to rule out the condition. About management, genetic counseling is an important part of overall management, and there are three types of treatment of WILM'S tumor that includes surgical part, chemotherapy, and radiation therapy. And moving on to the surgical management, for unilateral tumor, the partial or complete nephrectomy is has to be done, and for bilateral tumor the child may be treated with chemotherapy or radiation therapy before surgery, and can be partial nephrectomy can be done for the less affected kidney, and renal transplantation is the major treatment of the WILM'S tumor. Moving on to the chemotherapy is to treat any metastatic lesion that may exist and may destroy any cells in the bloodstream before they get implanted. And actinomycin D, vincristine, doxorubicin, and that is atreomycin with the addition of cyclophosphamide for the advanced disease. And stage 1 and 2 tumors can be treated with actinomycin D and vincristine postoperatively. And moving on to the radiation therapy is in advanced WILM'S tumor, that is stages 3, 4 and 5. This radiation therapy will be helpful, that is bilateral or large in size may be inoperable. For such cases, radiation therapy is used to reduce the size of the tumor so that surgery can be performed. Advanced method of treatment is stem cell transplant. Here that specialized type of cell with all blood cells will develop to maintain the blood constituents and also to maintain the growth and development in children during extensive chemotherapy and radiotherapy. Next, about the nursing management, here pre-operative care and post-operative care. And about the pre-operative care, prepare the parents and the child for surgery, and explain the parents not to palpate the abdomen of the child, and explain about the post-operative care to take care of the children. Cautions should be taken while turning and handling of the child. Moving on to the post-operative care, we have to monitor the vital signs, monitor the renal functioning by monitoring the weight, intake and output chart, and the renal function values, and observe the signs of functioning of the kidney. Use aseptic techniques while doing the dressing, and explain the parents about the follow-up and continuing the treatment at the time of discharge. Thank you.